we are going to discuss about the developmental disturbances. So first of all, developmental disturbances in size of teeth, right? So there are various disturbances in size of the teeth. First of all, microdontia. As the name suggests, the term is used to describe teeth which are smaller than the normal size. As we can see in the picture, this tooth is the middle tooth is smaller in size. Three types of microdontias are recognized: true generalized microdontia, relative generalized microdontia involving single tooth. True generalized microdontia is actually the tooth is smaller. Tooth contralateral or side, the tooth of the tooth in the side of in the both side, right? And microdontia involving a single tooth, in which case the single tooth is smaller than other teeth. Then come to macrodontia, as the name suggests, teeth which are larger than the normal. Again, there are three types of macrodontias are recognized: two generalized, relative generalized, and macrodontia involving a single tooth. Now, two generalized macrodontia, all the teeth are larger than normal, basically seen in case of pituitary gigantism, which is extremely rare. Otherwise, relative generalized macrodontia, again, the normal or slightly larger than normal teeth are present in small jaws. We can relate the jaw and teeth. Macrodontia involving a single tooth is very uncommon. Now come to developmental disturbances in shape of the teeth. Before that, we have done in size, then in shape. Now come to gemination, which is very important. Gemination teeth are anomalies which arises from an attempt at division of single tooth. Germs by an invagination with resultant incomplete formation of two teeth. As you can see in the picture, you can see it looks like a two teeth are merged. Otherwise, it is arises from an attempt to at division of single tooth, germ by an invagination, right? So it result in an incomplete formation of two teeth. Seen in both primary and permanent dentition, has higher frequency. It is higher in anterior and maxillary region. Incisor and canines are most commonly affected, right? So right, then after um, crowding and delayed or ectopic eruption of the underlying permanent teeth, and hence have to be extracted in certain cases. Lingual grooves are prone to develop caries because these are developmental grooves, right? So there are more chances of plaque retention, which is followed by caries formation, and hence in such cases Fisher sealant should be used. So we have to manage it with the Pitt and Fisher sealants. Now come to fusion. It arises through union of two normally separated tooth germs, which becomes one. So clinical features of fusion may be complete or incomplete. Tooth may have separate or fused root canals, demonstrate a pronounced labial or lingual grooves. Affects both primary and permanent teeth, again like the gemination, most frequently occur in the mandible region. That's why the picture is given. Just remember the picture. The previous one, this one has a picture of mandibular anteriors, most frequently occur in mandible. Fusion result in spacing, right? The labial and lingual grooves are prone. That's why we have to again seal it with the Pitt and Fisher sealants, right? Then come to concrescence. The teeth are united by the cementum only. It arises as a result of traumatic injury or crowding of the teeth with resorption of the interdental bone, so that the two teeth are in approximate content and become fused by a deposition of cementum. Right, the crowns are separated, the roots are fused with the help of cementum only. Most frequently seen in posterior and maxillary region. It can occur before or after the teeth have erupted. Right, the calcification if afterwards, then it results. Right, the clinical significance of is this: if we would like to extract the one tooth, if we are not aware of concrescence, then sometimes we can also remove the tooth with the concrescence occurs, can come out with the tooth which we are going to extract. Right, so we have to take care of that by taking the radiograph. And come to dilaceration. It is actually the angulation or sharp bend in tooth, root or crown of the tooth. It arises after an injury that displaces the calcified portion of the tooth germ, and the remainder of the tooth is formed at an abnormal angle. Clinical feature: most frequently affected teeth are the mandibular third molar. That's why if we are going to extract it or doing root canal treatment, there is unexpected response. Maxillary second premolar and mandibular. Right. Failure of the eruption is often seen because of dilaceration. Those that achieve eruption followed an altered path. Clinical significance: altered deciduous teeth often demonstrate inappropriate resorption and result in delayed eruption of the permanent teeth. Extraction is indicated in such cases, but we have to take care of the extraction as we can, so that we can remove it in one go, or we have to resect it accordingly by taking the radiograph or taking the measurements, all of them. Teeth with abnormal eruption may be exposed and automatically moved into proper position. Dilatated roots concentrate stress in the affected area if used as abutment. Splinting of the dilatated tooth to an adjacent tooth overcomes the stress-related problems. Then come to talon cusp. Talon cusp is an anomalous structure resembling an eagle's talon. Right, you can see here in the picture. Talon cusp projects lingually from the cingulum area of the maxillary and mandibular permanent incisors. Cusp bends smoothly with the tooth. Deep developmental groove is present where the cusp bends with the sloping lingual tooth surface composed of normal enamel, dentine, and contain a horn of pulp tissue. Most commonly seen in the association with the Robinson-Tavai syndrome. Tavai syndrome. The cusp on the maxillary teeth interfere with occlusion and should be removed. The developmental groove may be prone to caries. Sometimes you will get the cases through these grooves. We'll get the long-term chronic infections, periapical infections even, but we are not able to diagnose this. In endodontics, we can very well appreciate by taking radiographs, by taking CBCT. If you are not able to see the carious portion anywhere, just look. Now removal without loss of T may be accomplished through resulting in tertiary dentine if diagnosed earlier. If diagnosed later, then there must be invaginatus is a deep surface invagination of the crown or the root that is lined by enamel. It is coronal or radicular. Most commonly affected are permanent lateral incisors of the single external to the apex. And it is also called dens in dente. The first, it is confined to the crown only. Then second one, mento enamel junction and ends in a blind sac that may or may not communicate with the adjacent pulp or a root and perforate in the apical lateral without communication with the pulp. Last one, radicular dense invaginatus arises secondary to the pulp space, and which may lead to, if not detected earlier, may lead to periapical infection. So we have to treat it with the episectomy or by raising the flap, covering communication. Clinical significance in type 1 invagination. The opening of the invagination is restored after eruption to prevent caries. In invagination, the content of the lumen and any caries dentin calcium must be placed to micro communication with the pulp. Required in type 4 and surgical intervention is required. Then E. vaginatus appears clinical. You can see in the picture. It is a globule of on the glossal surface between buccal and linguals of the premolars. Imagination. Previous one was the imagination. That's why it is infold. It is evagination, often larger, often a inner enamel epithelium and odontogenic enamel organ during interfere with occlusion and should be removed. Remove with loss of vitality. Again, periodic reduction should be there. We have to do periodic reduction to prevent the non-vitality. Then come to taurodontism, enlargement of the body in the pulp chamber of the multitudinous tooth with apical displacement of pulpal floor. Radiographically, you can see affect teeth tend to be rectangular. You can see in the radiograph in the last picture. It has a rectangular shape. Increase in apical height. Bifurcation lies close to the apex. No cervical constriction. It may be mild, moderate, severe. Mild may be mild is called as hypotaurodontism, moderate mesotaurodontism, then severe hypertaurodontism. Right, no specific therapy is required, only operator skill is required to obturate it, right? They are ectopic collection of enamel. Sorry, I have a sore throat. Maybe voice is not clear. They are ectopic collection of enamel. These are hemispherical structures consist of enamel or may contain dentine and pulp. Odontoblastic layer, which provides prolonged contact with Hardwick root sheath inductible formation. Most frequently found in the root of the maxillary molars. Just remember this, right? They appear as well-defined radiographic nodule along with the root surface. Area of radio density extending from the dentinal junction to the coronal dentine, right? You can see in the picture. Weak periodontal attachment. Hence, meticulous oral hygiene should be maintained. Occurs along the surface of the root. These extensions represent a dipping of the enamel from the CEJ towards the bifurcation of the molar teeth. Mandibular molars are more affected commonly. Mandibular molars, right? Cervical enamel extension has a weak periodontal attachment again. So we have to take care of oral hygiene. These have been associated with the formation of the buccal bifurcation cyst.